STEMIs here.
Oh, exciting. It'll be my first one.
Oh, no, it'll go straight through to the cath lab.
Oh, okay.
Yeah.
Hey guys, this is that STEMI that I've called through.
Yeah,
They're still stable.
Yeah, cool. Straight through.
Cardiologist.
Yeah.
Hey, we've just had a pager through from this GRN scanner. We've got a 52-year-old male coming in with a STEMI. It looks like anterior ECG changes. Then he's got a G10 infusion going at the moment, but I could still hear him in pain in the background. He is hypertensive with an increased rest rate, and he's going to be here in about 10 minutes. I've already told Lauren and Rebecca, and they're getting resus ready.
Okay.
So, Fiona, I've managed a couple of these STEMI cases. Do you mind if I team lead this one, and if you could supervise me and support me with this?
Yeah, absolutely. We could do it as a mini CX if
That'd
you
be
like.
great. Thank you so much.
And would you like to come and be the cert doctor?
That sounds great.
This is Tony, he's 52 years old. He's had 2 hours of central chest pain, which we've called a code STEMI on. He developed the chest pain at rest while he was driving his car, and he's pulled over and called the ambulance. He has a known history of ischemic heart disease, but we weren't able to ascertain any other details about that or what medications he's on.
It just hurts like hell.
He's had 300 milligrams of aspirin and several doses of sublingual GTN, which we've switched to an IV infusion now due to refractory pain.
Yep.
He's remained hemodynamically stable throughout, with a blood pressure of 140 on 80. His ECG's sinus rhythm with ST elevation in the anterior leads. At this point, I think we need some analgesia for his pain and consideration of some reperfusion. Yep.
Hi Tony,
G'day.
I'm Emily.
Yeah.
I've just heard from the paramedic about what's brought you in. Is
Yeah.
there anything else that you'd like to add about
I think some heart stuff, but I'm not really sure.
that? Okay.
Oh,
Can
just
you
this hurts so much.
tell me about your pain? Where is it exactly?
Right, it's middle of my chest, just
Yeah.
like something sitting on my chest.
Sitting, so like a crushing
Yeah,
kind
that's
of?
15 out. It just won't go away. It's horrible.
Yeah.
It's horrible.
Like the worst pain that you can imagine?
Yeah, worse than the worst pain I can
Worse
imagine.
than you can imagine, okay.
Worse than anything.
Okay, is it
Oh.
radiating anywhere to your neck, to your arm, to your back?
Nah, it's just right in the middle and it
Right.
just won't go away.
Okay, is there anything that makes it better? Positional changes?
Nah,
Anything?
nothing I do
No.
makes it go away.
No, and I see you're a bit short of breath at the moment as
Yeah,
well. Is that
yeah. Feel like I need to take deep breaths, but I just can't.
You
Can't
just
get a
can't,
breath
yeah.
in.
Yeah, I see you're a bit sweaty as
Yeah.
well, so feeling pretty awful. Is
Yeah,
that
not
correct?
feeling real good at the moment.
Yeah,
Oh.
okay. And have you taken anything for this chest pain?
Nothing other than what the ambulance gave me. That
Okay.
nothing's really doing anything. It just won't go away.
And have you ever had this before?
Oh, not that I can remember, really. Oh, not at the
Okay.
moment. I'm not thinking real straight. It's
Okay,
just like,
no, of course. I'm going to do a quick assessment of you,
Yep.
okay? I can see you're talking to me, but obviously it's a bit struggling.
yeah, it's
struggling
not,
a little
not
bit.
much fun at the moment.
Yeah. I'm going to get some vitals
Yep.
from you. I think the nurse has already started getting those.
Yep.
And your breathing, I'm going to just check your ears in midline. It's okay. Oxygen saturation is looking okay. I'm just gonna. Can I just check your pulse, please?
Yes.
Yeah.
Oh.
Okay. And I'm just gonna have a listen to your heart as well.
Mm-hmm.
Okay. And can you just look that way for me, please? Thank you. Okay. Any tenderness in your calves or anything?
No, legs feel fine.
No. I'm looking for some swelling here as well. Okay. I'm just going to hand over. So there's no additional findings from what the paramedic told me just before.
Yeah.
And I'm just going to take some blood now as
Yes,
well.
please. Thank you.
Thank you.
So on the 12 lead ECG appears to be an anterior STEMI. Are you happy for me to continue the protocol of STEMI protocol?
Agreed, that's an anterior STEMI with some reciprocal changes here. And yeah, carry on as per STEMI protocol.
I'll get the assessing doctor to contact the cardiologist, and are you happy for me to go ahead with the thrombolysing?
Assuming that you've gone through the contraindications.
Correct. I will be doing that with the patient. Okay, thank you. All right, Tony.
Yeah, doc.
Now, the heart film, the ECG, shows that you've got a heart attack.
Right,
Okay.
yeah.
So we're going to need to treat that.
Mhm.
Now, there is a medication that we can give you,
Yeah.
which is the only treatment that we have in the rural and the locally that we can help with this, is a medication to basically break the clots and get the blood circulating around the heart again. Okay.
Yeah.
Now, I'm just going to ask you a few questions.
Yeah.
Have you ever had issues with bleeding anywhere?
No.
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 Are you on any blood thinners?
No.
No. Any strokes or any headaches at the moment?
No.
Any weakness in the arms or legs?
No.
No. And have you recently had any procedure or surgery done?
No.
Nothing like that.
No.
Okay. Now, the risk of this medication is bleeding, and one of the areas is in the brain.
Right.
Okay. Now, but the benefit and the risk of having this medication is significant, that we need to give you these treatment.
Yeah.
Because if we don't do anything, that could lead to worsening heart attack and could lead to death. Okay.
Right. Yeah.
Okay. Now, do you understand the risks that comes with it?
Yeah. So risk of maybe a bleed.
Correct.
Yeah.
Yeah. Are you happy for us to continue with that?
Yeah.
Okay. All right. Thank you.
No worries. Thanks, doc.
Lauren, have you drawn up to next plays before?
I've never even seen it used before.
No, that's all right. So comes in the box,
Yeah.
pre-filled syringe.
Yeah.
What you need to do is just add on that plastic cap like I
Okay.
have, add the water, give it a little bit of agitation, should start dissolving straight
Yeah.
away. And what you'll see on the syringe is that the recommended weight dosages are already written on there. So you can
okay.
always double check what the doctor's prescribed to
Yeah.
make sure that it's correct, which is always a bonus, particularly when we're giving it in a hurry.
Yeah.
So once it's fully dissolved, just draw it back to the recommended dose,
Yeah.
twist the cap off, and you're good to go.
Right. So let's just summarize. So we've got the aspirin on board.
40s in.
Thank you, Rebecca. So can we prepare IV enoxaparin of 30 milligrams as a bolus?
Yeah.
And the second will be a 1 milligram per kilogram subcut of Claxane. Once those done, can you please feed back to me?
I'll get 30 milligrams of IV Claxane, and also can we get some fentanyl for his family?
Yep.
Can I suggest using morphine instead?
Morphine?
Morphine?
Yep.
Yeah.
Perfect. We'll switch to morphine, Rebecca.
Oh, that'd be good.
Thank
Something
you.
needs to get this pain sorted. It's not
Um,
going anywhere at the moment.
So on medication, and in the meanwhile, I'm gonna contact, or Lauren, if you could contact please MedStar and contact the cardiologist
Yep.
to send them a photo of that ECG as well. Once the
Now, do you have any allergies at all?
Not that I know of, no.
No. Any past medical history?
Yeah, I had some stents done in Victoria.
Okay, how long ago was that?
Oh, a while now. Can't
Yeah.
remember exactly.
Okay, what medications are you on?
Oh, I stopped taking them about a week ago.
Okay, do you remember what they were?
Nah, not
Or
really.
what
I
they were
just-
for?
After I had my stents, they gave me some stuff to take, but
Okay.
I was feeling pretty good, so
Alright, so
didn't need
doctor
them
didn't
anymore.
tell you to stop, you
Nah,
just went,
nah,
that's
I just-
enough, don't need this
Yeah,
anymore,
I just
and went from there.
stopped taking them.
Okay, alright. And what time did your chest pain start?
About 2 hours ago.
2 hours ago. And has it been getting worse, staying
Nah,
the same,
just
or up and down?
Hard and fast and hasn't eased off at all. Probably
Alright.
10, 15 out of 10.
Did those drugs that SAS gave you
Not really.
help
Nothing's
at all?
really helping
Alright,
with
I'm
the
going
pain
to
at
give you
the
another
moment.
dose of morphine, okay? Have you had morphine before?
Maybe.
Maybe. You might have had it before, previous operation. Alright, so I'm just going to give you a dose now.
Yeah.
Might feel a little bit warm going through.
As long as
shouldn't
that helps
sting
his
too much.
pain, I'll be happy.
Fair enough. All right, now this one's just a bit of a flush.
Alright. Oh,
There you go, all done.
thank you.
There. They'll take about 2 minutes or so to
Okay, hopefully.
Okay.
Nothing's worked so far.
Oh, I'm sorry. Should start kicking in pretty quickly though.
Mm-hmm.
But the docs are having a chat. We'll be getting some other meds into you to help along with this, okay?
Okay.
Perfect. Perfect. All right. How's the pain, Tony?
It's not going anywhere
going.
at the moment. No,
Alright.
it's still there. It's still like 15 out of 10. It's
15
not
out of 10.
stopping.
Rebecca, can we please get another fresh set of obs,
Yeah.
mainly the blood pressure? And if there's room, can we please give him a little bit more morphine?
Yeah, of course.
And Josh, do you mind titrate the GTN infusion a little bit more? So just let's increase it by 10 mics per minute.
85.
So 85 at the moment, yes please.
Thank you. Oh,
Alright.
someone's got to stop this pain. It's just not going
And
anywhere.
just to summarize at the end of the 60 minutes, we need to repeat the ECG to
Yeah.
see where we stand.
Okay. And I guess my only question,
Yeah.
like, because this patient's obviously got a STEMI,
Yeah.
but is it the same stuff that we use for a code stroke as well?
Yeah, for us, exactly the
Okay,
same. If
alright.
you do like a metro placement, you
Yeah.
might find that they use a different kind of medication,
Okay.
but for us, we use the same
Okay,
drug,
alright.
whether it's a stroke, an MI,
Yeah.
or even for patients who are in cardiac arrest, sometimes you do need to
Yeah,
give it in those
yeah,
cases.
yeah.
If they are a pulmonary embolism or a myocardial infarction,
okay.
we're going to give that exact
the same.
same drug.
Yeah, okay.
One thing to be wary of, once we've given that, it's a quick push, only 10 seconds.
Yeah.
But with this particular patient, because they are a STEMI, we've
Yeah.
got to keep an eye out for VT and VF in particular.
Okay, right.
So defib pads on the whole
Yeah,
time, and they
okay.
have to be one-on-one nurse.
And so then why did they put them, I saw that he had them on the front and the back
Yeah.
instead of like when we do them for BLS.
yeah.
So why did they do it that way?
So we're looking at that electrical impedance. The best way I can think about it is it's like a heart sandwich. So you want to have that heart sandwich between the two pads so that
Yeah.
you've got the best chance of that electricity getting through.
Yeah, okay, makes
So
sense.
that, yeah, you've got less
Yeah.
resistance for it to be travelling. Say if
Yeah.
you've got it up
Right,
here
along
and
across.
here, it's going to take
Yeah.
a while for it to get through.
Yeah,
Whilst
okay.
if we're here and here,
Yeah.
it doesn't have a lot of space to travel through.
Yeah.
And also think about where we've got our ECG leads for a 12 lead ECG.
Yeah.
If we've got a pad right here, we're not going to be able to get V5 or V6. So it's also got
Right.
that added little bonus
For this
that we're going to
particular
continue
case.
to get accurate ECGs.
Yeah.
All good?
Great, makes sense. Thanks
Awesome.
so much.
And I'm just going to confirm this with my consultant. I don't see any changes on the ECG. The pain is still persisting.
Looks the same as
Yeah.
earlier, doesn't it?
Yeah. I think in this step, I think we might need to have a conversation with a specialist.
Hello, Fiona speaking. Yeah, hi Prof, thank you for calling. So you've got the cardiologist on the line as well, yeah? Okay, fantastic. Yeah, so we're here with Tony. We're an hour post tenecteplase, still with no resolution. So ST segments remain elevated. His pain is ongoing despite escalating doses of GTN and morphine. I guess we're starting to wonder whether perhaps a second half dose of thrombolysis might be indicated in this patient. I'm wondering what you think about that. Yeah, no change at all. Yeah, exactly the same. Yeah. No, I understand some limited evidence, but I don't know that we've got much else that we can do in this case. Yeah, no, okay, all right. Yeah. Well, we'll discuss with the patient and explain the increased risk. Okay, not a problem. No worries. Yeah, thanks. We'll see you in about an hour and a half. Okay, thanks, bye. So yeah, that was cardiologist and the retrieval consultant. They're in agreement. They in this case might be worth a shot with a second dose of thrombolysis.
Okay.
So yeah, we're going to use half dose this time. Are you happy to consent the patient
Perfect.
for
I'll
that,
go ahead with
explaining
that.
that the bleeding risk is increased with second dose?
Awesome. Thank you.
Fantastic. Thank
Cheers.
you.
Now, Tony,
Yeah.
the outcome of the conversation of the specialist,
Yeah.
they concluded that we might need to try another dose of that medication. It's going to be a half dose.
Yeah.
However, the risk of bleeding is going to increase.
Okay.
Again, the risk of benefit, if we don't do anything, you might
Die, basically.
That's right.
Yeah. All right.
So would you be happy for us to continue with the half dose?
Yeah, I'm
Okay.
happy to try again.
All right.
Anything, if it's going to get rid of this pain, I'm happy to try again.
All
at
right,
the
we're
moment.
going to do 25 milligram per gram connector plays. Can we please give him 20 milligrams?
20 milligrams.
Yep, and we're going to repeat the ECG monitoring every 15 to 30 minutes. Thank you, Rebecca. Oh, sorry. How's your pain at the moment, Tony?
It's still
the
like
same?
10 to 15 out of 10. It's
Yep.
like just hasn't changed much at all.
Especially for arrhythmias, for hyperfusion, signs of bleeding, and especially we're going to do some neurological
I hate that
assessment
stuff,
as well,
so
if he complains of headaches or anything like that.
Oh, okay.
And obviously continue close monitoring all
Thank
the
you for
vital
looking
signs.
after me.
Yeah. Tony, how's your pain at the
Pretty
moment?
much.
Is that ECG
Pretty much
30
gone
minutes after
now.
second dose?
Pain's
Okay.
good, Doc. I think you fixed me. Do I really have to go? Anyway, I feel pretty good now.
Well, I'm glad you're
Oh,
feeling
the
good.
pain's-
The ECG is looking better.
Yeah.
Would you agree with that?
Yeah,
Fiona?
absolutely.
Yep.
There's resolution of that
That's right.
ST changes, isn't there?
So that just shows that there's a perfusion back. The,
So I s-
the heart muscle is getting the
So does
blood
that mean
supply.
you fixed me and I can go now? Or do I
No,
have to
unfortunately,
stay?
we're still going to need to send you to a tertiary hospital,
No.
okay, to look
Yeah.
after you, to have a
Right.
better outcome. And the plane
But I
has...
feel really good now.
Well, that's,
Like-
I'm glad. We're going to lower the medications,
Yeah.
and we're going to send you to the metro, okay?
All right.
Now, we have the plane landing, so they should be picking you up in the next 30 minutes.
Okay.
Okay?
All right.
All right, if
So I
you-
really still need to go, yeah?
Yes,
Okay.
yes. If you have any pain or any other symptoms, please
No,
let us
pain's
know.
really-
Okay?
My pain's really good now. It's like
Good.
pretty much no.
Good.
I'm
Glad to
feeling
hear.
heaps
Glad to
better.
hear.